thank you for joining this panel discussion. Dr. Sharma and I are each going to be presenting for about 10 minutes. I'll take questions right after my talk for about 5 minutes, and then Dr. Sharma will speak for 10 minutes and take questions for the last 5 minutes. My topic today is restless leg syndrome, and I've got a few slides and just trying to present some of the basics here. And I want to thank ALD Connect and Dr. Eichler for inviting me to participate today. Many of you may have never have heard of restless leg syndrome or think that it is something that was invented. I hear from people, some doctors and patients, is that really a thing? And in fact, it really is a thing. And if you ask anybody who has it, they will tell you it really is a thing. And here you see kind of the first description that we've been able to identify from the historical literature from a very famous physiologist and physician named Sir Thomas Willis. And he said, "Wherefore to some, when being abed, they betake themselves to sleep, presently in the arms and legs leaping in contractions of the tendons, and so great a restlessness and tossing of their members inshore, that the diseased are no more able to sleep than if they were in a place of the greatest torture." And if you show that to somebody with restless leg syndrome, they say, yes, that's it. 350 years later, I'm not sure we've seen a better description of this. Here's something from the New York Times about 20 years ago, when RLS was becoming more recognized in the United States, although it had been described in the medical literature in the 1950s in great detail. And here you see Jane Brody just saying that this was really actually quite common and quite treatable if it was recognized. And that's really the key. Do you recognize these symptoms? And then if you talk to your doctor about it, do they recognize these symptoms as a neurological disorder? Now I think awareness is better than it was 20 years ago, but still many people are not aware that this is a legitimate neurological disorder. So we've got an acronym for this that is urged, URGED. And this is how you make the diagnosis. It's pretty straightforward. The U is there is an urge, or some might say even a need to move the legs, usually accompanied by an uncomfortable or unpleasant sensation in that limb. And usually most people don't describe it as pain. It's tingly, achy, creepy crawly, something crawling on the skin, tense, sometimes painful feeling, usually deep rather than superficial. This urge or need to move presents at rest. It starts when people are sitting or lying down. And then if you get up, really within a few seconds or certainly a minute of standing up, it goes away. So this is the G. And the interesting thing, one of the interesting things about this disorder is that it is predominantly present in the evening or at night. So you can sit or lie down during the day, and usually it's not so bad, but when you do the same thing in the evening, or certainly when you get into bed, that's when it attacks. And there are things that we're going to talk about that seem to be restless leg syndrome, but are probably not, but have some of these characteristics. Here's a little cartoon. For many people, the diagnosis is obvious. And here you see the doctor saying, we're pretty sure it's the West Nile virus. Many times people come in and say, I've got these symptoms. And I say, well, that's restless leg syndrome. But there are certainly another group of people, and in the ALD women that I've seen, I would have to say many fall into this category where it's sometimes difficult to tell whether it's really restless legs or not, because there are a bunch of other things that are going on for such people that sound like restless legs, but probably in the end really aren't restless legs. So you have to be careful in making this diagnosis. And what are the things that are the mimics of restless legs? Well, leg cramps. So people can have nighttime leg cramps that wake you up. We might call these a Charlie horse, where the muscle actually goes into spasm, usually in the calf, but it could be in other places like the foot. And that is not restless legs. That's something different, nocturnal leg cramps. Then neuropathy, which many people with ALD will also have neuropathy, and that can simulate restless legs, but the feelings are oftentimes different. It's actually a numbness in neuropathy or a burning, and there really isn't this urge to move the legs. And moving generally doesn't help peripheral neuropathy. But neuropathies can certainly get worse at night, just like restless legs. Arthritis can simulate restless legs, where people have discomfort in the joints that oftentimes hits them in the morning rather than at night, and also improves once you start moving. So that can be misconstrued as RLS. People can have feeling varicose veins or peripheral vascular disease. With peripheral vascular disease, oftentimes moving makes it worse, not better. Sometimes people will just cross their legs in a funny way, and then the leg goes to sleep. And then if you uncross your legs, then it kind of wakes up. Sometimes I wake up in the morning after I've been sleeping like this and one of my arms is asleep. That's not restless legs either. So the prevalence of restless legs is, you can see, dependent on sex. So women have it about twice as often as men, and it goes up with age. In general, if you take all adults in the US or in other Western countries, the prevalence is about 2.5%. So 2.5 people out of 100 will have restless legs in the US. Why do we care about restless legs? Well, the reason why we care is because it usually disturbs sleep. That's why people come to the doctor, because they say, in the evening, I feel a little bit nudgy when I'm watching TV. I get in bed and my legs won't let me sleep. I have to stretch. I have to get out of bed. I have to walk around. I wake up in the middle of the night and that happens. So this is why people come to the doctor, is because of sleep disturbance. Also, once people with restless legs go to sleep, they'll have these what are called periodic leg movements or limb movements of sleep. Every 15 to 20 seconds, they'll get a small jerk of the foot or even a much bigger jerk of the whole leg. And that's really characteristic. That's present in almost everybody with RLS. It can be present in other people who don't have RLS, but almost everybody with RLS has that. People with RLS report reduced health-related quality of life, increased rates of mood disorders and anxiety disorders. And we have shown that that RLS does seem to confer risk for future cardiovascular disease, whether that be heart attacks or hypertension or potentially even stroke. So I think this is my, whoopsie, it was my last slide and then I bombed it out, didn't I? Let's get it back. Come back here. There you are. So I just want to close by saying that there are really good treatments for restless leg syndrome. There are 4 treatments that are FDA approved for restless legs. And these are, 3 of them are dopaminergic drugs. So they're very low doses of medicines that are used for Parkinson's disease. This would be ropinirole Requip, pramipexole Mirapex, rotigotine Nupro. They're really good medicines in the short term. Over the long term, they can cause problems, making the RLS worse. There's also this other class of medicines that includes gabapentin and pregabalin. Those drugs formerly known as Nutan or Lyrica are also helpful for restless legs. And in people who have low iron, giving iron by mouth or IV can be helpful. And if all else fails and symptoms are really bad, we will use opioids, in very, very low doses. And these medicines appear to be effective over the long term. So oxycodone, tramadol, hydrocodone, I see a lot of people with very severe RLS who have it most of the day. And so I use long-acting opioids like methadone. These are not approved for restless legs, but generally are very well tolerated, produce no high or even addiction, meaning misuse or abuse, in the vast majority of people. But just to make clear that if you have this problem and if it is interfering with sleep, going to see your doctor, saying, I think I might have restless legs, discussing various treatment options could really change the quality of your sleep. And if your symptoms are severe, the quality of your overall life. And I'm going to finish on that note. And I see I've got some questions here, which I'm going to answer in the last 4 minutes. Are there any factors that increase the frequency of RLS? This is from Anonymous. I feel like mine gets worse when I'm overtired, but maybe that's something else. Yes, absolutely, Mr. or Ms. Anonymous. I hear this from a lot of people, that fatigue makes RLS worse. So certainly the end of the day promotes restless legs, and this is a circadian effect. But if you are particularly fatigued, even in the afternoon, that can bring it on, which is really a drag for people because that's the time when they want to sit down and or even lie down. And that's when RLS gets you, is when you're sitting or lying down. So Cindy asked the question, is MRI a good tool to measure affect on women? I think that may mean effect on women. We don't use MRI to diagnose RLS or determine whether it's effective or not. So MRI is really not used for diagnosis or treatment purposes. Sydney says, I have what feels like itchy muscles. Touch on the outside doesn't fix it. That could be it. The question is, does it meet those criteria, the URGE criteria? Is there this feeling that you have to move? Is it predominantly present when you are sitting or lying down at rest? That's the R. Does it get better if you stand up and walk around? And is it mostly present in the evening or at night? What you have is itchy muscles, could be restless legs. I spend, when I see patients, certainly 15 or 20 minutes just trying to figure it out for some people. So it's hard for me to know right now if this is or isn't RLS. Mary asks, what non-drug approaches are used to treat RLS if you're not low in iron? Staying busy, staying active, not lying down, not sitting down will generally, you can avoid having symptoms if you're doing those things. Unfortunately, sleep usually happens when we're lying down or maybe sitting down. So it's going to get you when you are resting. But keeping, certainly during the day or in the evening, staying active will be helpful. Many people find that things that occupy their mind improves things, whether it be playing video games or even something like knitting. Sometimes people find massages helpful. Sometimes people find exercises helpful. Not too much exercise, not too little exercise. There's a kind of a Goldilocks level, and those can both be helpful. Unfortunately, these non-medication approaches for people with at least moderate RLS are not so helpful. Linda says, to confirm, is RLS separate and distinct from the involuntary contractions and clonus that naturally occurs as a result of AMN in women? Yes, RLS is distinct from these involuntary, from clonus for sure, but do recognize that during sleep and even sometimes during wake, people with restless legs, if you don't dissipate these feelings and you force yourself not to move, people will have involuntary brief jerks of the legs. And so this can be sometimes difficult to distinguish from clonus. And this is why we spend a lot of time trying to figure this out. Dr. Eichler and I are doing interviews with a lot of women with RLS, with AMN, ALD, trying to see if, in fact, what percentage of people do have true RLS. And I have to tell you, it's oftentimes difficult to figure out whether this is really RLS or not. Finally, Marie asks, what type of exercise helps more to relax the legs? You know, it's not clear to me whether there's a particular exercise. I think I hear people getting on exercise bicycles, people walking. It's not clear that there's one type that is better than another, but I think too vigorous exercise can actually make RLS worse. So on that note, Dr. Sharma, who's been very patient here and has some really fascinating things to talk to you about, will start her presentation. I'm going to stop sharing my screen, and I want to thank everybody for the really good questions. Dr. Sharma, it's up to you now.
Okay, thank you. All right. Well, hello, everyone, and thank you for inviting me to speak today. I hope that you can see my screen. I wanted to just speak briefly about what we are finding about distinct movement disorders in women who carry ALD. And this is based on work that we have begun to do with Dr. Eichler, evaluating women. There are different types of movement disorders that we are finding that women have, and they're classified as dystonia. Dystonia is just uncontrolled muscle contractions that cause abnormal postures. One of the most common forms of dystonia in adults, whether they carry ALD or not, is uncontrolled turning of the head and neck, so that someone's head turns to the right or to the left, or their head may tilt down, and there may or may not be a tremor associated with it, so a little shaking of the head and neck as well. People can have dystonia that affects their ability to write. So when they grab a pen, their arm becomes elevated and their hand becomes twisted. Whereas when they use their hand for any other fine motor task, they have no difficulty. People can also have a tremor, either in their hands or in their neck, most commonly. And lastly, people can have ataxia, coordination problems. So most commonly, we ask people to move their finger and hit a target, and we'll find that there's some trouble reaching the target accurately. We are just beginning to evaluate people in the Dr. Eichler's clinic at Mass General, and what we're finding is that 18 to 19% of the women who are evaluated also have a movement disorder. The most common is dystonia affecting their neck. They can also have tremor, and some have some ataxia, some difficulty with coordination and reaching a target accurately with their fingers. Commonly, people ask, because it also was in the title of this talk, what can be done about prevention? With all movement disorders, regardless of the underlying cause, we actually do not know of anything that can prevent it. And so I always tell people to remember that there is nothing that you should have done, nothing that you did nothing that you should not have done that caused these movement problems or not. We simply do not know what brings them out in some people and not in others. Lastly, most importantly, I think, is their treatment. Even though we do not know what causes these movement disorders, we can treat them. So for dystonia, for the uncontrolled contraction of muscles, we most commonly use botulinum toxin or Botox. Believe it or not, Botox was actually developed for medical reasons, not for making us all look younger. It is a pretty safe treatment because it is just injected in the muscles that are affected, and it helps to relax them. If you do not like the effect of Botox, the effects wear off after 3 months. But if you do find that it was helpful, then the downside is you have to keep getting regular treatment. There are some oral medications that we use to try to relax the muscles, most commonly clonazepam and trihexyphenidyl. They both have some side effects, making people feel a little sleepy or out of it. For tremor, I usually like to start by having people experiment with modified utensils, uh, weighted utensils also that are bigger and thicker, the same with pens if a tremor interferes with writing. Because we do much more typing than writing these days, um, I find that some of the modified keyboards and a computer mouse that actually has a roller ball in it can help as well. Um, and all of these things are easily ordered these days so that they can come right to your house and you can experiment with them. There are a variety of medicines also that can help to reduce tremor. Uh, they the choice of which medicine to use is very much based on what the potential side effects are for each medicine and a person and what other medical conditions and prescription medicines a person may be on. And I think that was all that had prepared. It looks as if there are some questions. So let me see. Yes. So the first question from Alex is massage something that women should seek for neck dystonia? So one has to be careful. A light massage can be helpful, but frequently a deep tissue massage, for example, a type of massage where the therapist really kind of presses deeply into the muscles can actually make the dystonia, the contractions worse. As far as I know, health insurance does not cover those massages. I see a lot of people with dystonia, and I am not aware of anyone who has been able to get it covered. The other thing that does help to relax muscle is moist heat. If you have a hot tub at home or have access to one, that can be helpful. Then let's see, Katie asks if there is any MRI correlation with movement disorders. There is not. So in fact, current MRI protocols, current brain imaging protocols do not help us really do not help us at all with movement disorders. It is very much old-fashioned clinical assessment to figure out, one, what type of movement disorder someone has, and two, what is the best way to treat it. The problem is that MRIs give us really great detailed pictures of the anatomy of the brain, but in movement disorders, the problem is in how the brain is sending a signal to the body, and we have no way of looking at that or measuring that. Karen asks that she has hypertonia in the Achilles tendon, which reduces her ankle flexibility. Interesting. And is that hypertonia? So if it is in the tendon, then it is not a dystonia, it is not a movement disorder. If it is in the muscle itself, the muscles of the calves themselves, then it may be partly due to uncontrolled muscle contraction. And then treatment would be different. So I think my first question is it just in the tendon, or is your tendon popping out because the muscle is overactive? And then lastly, is it Karine asks that she has tendinitis very often. And is that a normal thing? Partly it depends on where you have the tendinitis, so is it in the same limb, in the same area? And my first question would be, well, on a daily basis, how are you moving that part of your body? Do we think that there's any element of overuse that plays a role in it first? And also depending on what joints are affected, it may be more common in women. But again, it depends on what joints are affected. And I think, oh, what group is the 19% out of? So we are evaluating, there are a number of women who are participating in research through the ALD clinic with Dr. Eichler. And so out of all the women who've been evaluated so far, which I believe are 56, we're finding that 19% of them have some evidence of movement disorder on exam. Okay. So I think that's it. And this is, I'm hopeful that we'll have more information for you next year as we continue to evaluate people and try to understand what is contributing to the movement disorder, and try to understand why some women are developing a movement disorder and others are not. So thank you very much.